Welcome back, everybody. What a fantastic and fascinating conversation with Representative DeGette and Ken Mankhouse. As we head into our second half, again, please be reminded that to capture your questions for our live Q&A session, and at the end of the session, as a reminder, we'll be taking your Q&A, and you can drop your questions in the box on the right here, as you can see. Our next segment is a case study on prevention. I spoke about this in my first session, and it will be presented by Dr. Brian Trainer. Dr. Trainer is a neurologist and senior investigator at the National Institutes on Aging at the National Institutes of Health, and adjunct faculty at Johns Hopkins University and Queen Square Institute of Neurology, UCL. Dr. Trainer is best known for his work aimed at understanding the genetic etiology of ALS and FTD, frontotemporal dementia. He has over 200 publications in professional journals, so it's unbelievable. And I'm so excited that Dr. Trainer is speaking with us today around how genetics can be leveraged to reduce risk of ALS. Dr. Trainer, the floor is yours.
Great, thank you. Can everybody hear me? Dave, yes? Do I have the thumbs up? Yes? Okay, so Dave is mission control here, so I have to make sure that I get the thumbs up from David. So it's a pleasure. Thank you very much to COLDUP and to the ALS Association for the invitation to speak today. It's a shame. I always like speaking in front of an audience, so it's kind of a bit different for us to do it this way. But the year that's in it, this is the way we have to do it, and hopefully next year we'll be back to doing it in person. So what I've been asked to talk about today is a little bit about how could we go about and sort of maybe a utopian vision of how could we prevent ALS ever from occurring in the first place. And this is a theme that's very close to COLDUP's and to Neil's heart and to everybody at the ALS Association. And really, we've been having discussions in the background talking about ways in which this might actually happen. Now, this may sound a little bit fanciful, but I will tell you that because of my work in other areas and other neurological diseases, it is fascinating to recognize that other diseases and other disease communities are actually thinking along the same lines, particularly on the dementia side of things. So I don't think that we're a million miles away from what we should be thinking about and what we should be talking about. So with that, this is the slide that you have up in front of you. Actually, go back one if you don't mind. Is my various sort of funding. If anybody wants to ask me why the Italian Football Club Association was funding me, it's a great story at the end, so I'll certainly be happy to tell that. Okay, let's go to the next slide, Adam. All right, so I actually believe in giving the message up front when I'm talking in giving presentations. And here's the key message. I actually think that we can prevent ALS by 2030. Now, I know that it says 2040 up there, but I know that COLDUP and Neil have been talking about 2030. So that's in your minds, change that to 2030. And in order to achieve that, we have certain obstacles or certain milestones that we have to achieve. First and foremost, we have to know what the genes are that cause ALS. We need to design gene therapies. And bear in mind that when we're talking about designing gene therapies, that's kind of happening for all diseases at the same time. So it's not unique to just ALS. And indeed, a lot of what I'm talking about putting in place applies across the gamut of all diseases. So again, it becomes into that realm of really thinking, this isn't too far away from reality. The third point is we need to be able to diagnose everybody at birth. And that's something I'm going to touch on a little bit later as to why I think that's actually important and why we think we should be going forward with that. And then the last bit is, and it's a shame that the Congresswoman isn't here because we need money. That's basically the green poultice is basically what we need in order to move the ball further down the field. And I think that everybody would appreciate that a lot of what we're talking about is actually going to be dependent on the research funding. And just before we go to the next slide, just to put this into context, into historical context, I have a picture there on the right-hand side And if anybody actually knows who that is, could they quickly put it into the chat just to let us know who they think it is? And I'll pause there, and I'll give you the clue is the dog standing in front of them who looks very, very nervous. I'll tell you that. No takers. All right, so this is why I like having a live audience instead of doing it remotely. It actually is Benting and Best. And Benting and Best are famous in the 1920s, early 1920s, of figuring out a way of getting insulin out of the pancreas of dogs. And that insulin could be used to treat diabetes, type 1 diabetes. And up until that time, until they actually figured out how to manufacture the insulin, a diagnosis of type 1 diabetes was uniformly fatal, usually within 6 to 8 weeks. I mean, this is a disease that was just completely, if a child or a young adult was diagnosed with it, that was it. It was curtains for that person. With the invention of insulin and the way to actually extract it from in a meaningful way and produce it in a meaningful way, it turned diabetes into, this is a disease that we could treat and we could keep going with, and not actually necessarily fatal. Of course, there are a lot of side effects, a lot of problems with diabetes, but I think that the point still stands that, there are many diseases today that we think of as treatable that in the past were not. And hopefully we can move ALS into that particular realm of disease. Next slide, Adam, if you don't mind. Okay, so here's what I'm briefly going to touch on today. I am going to talk rather fast, so if there's anything that you want to go into more detail at the end, please let me know. I'm going to talk about the impact of ALS. In other words, why is it important for us to focus on ALS? Talk about genetics of ALS because it's kind of a lever into the last bit, which is really the gene therapy, which I believe is the way in which we can move forward and actually ultimately prevent this disease. Okay, Adam, next slide, please. All right, impact of ALS. Next slide, Adam. Okay, so just very briefly, this is a nice little study that was done by somebody working in my lab, Carissa Arthur, where she took what was known about the epidemiology of ALS around the world. She calculated how many cases of ALS were alive in 2020 or 2015, and then worked out how many there are going to be in 2040. And lo and behold, what she found was that the number of cases was going to go up around the world to about 400,000 cases, representing an increase of about 69%. Now, you can say, oh, wow, does that mean that the population of the world is increasing by 69%? No, that's not what's happening here. What's happening is, remember that ALS is a late onset disease. The world population is actually quite young. And there's a bolus of people, billions of people who are going to come into late middle age and late age, and they're going to be at risk of ALS and subsequently develop ALS. And that's what's accounting for this swelling in the number of cases. Next slide, Adam. But what's even more dramatic about that is that if you think about that calculation, how Carissa actually did that calculation, it was based on the assumption of survival of ALS patients of about 3 years. And actually, if you think about it, if we manage to increase the survival of ALS by just 1 year, we're going to increase the number of patients that need to be treated with ALS and taken care of with ALS by up to 1/3. And when you say this, and oftentimes I do actually go out and advocate to drug companies to try and get them to invest money in dollars into ALS therapies, the eyes kind of light up and they begin to realize that actually there's a significant patient population out there that they can actually work on and potentially generate some revenue from. So it's an important point to make and to get across, I think, particularly to pharmaceutical companies that might be interested or thinking about getting involved in ALS research and pharmaceutical development. Next slide, Adam. Okay, so let's talk a little bit about what I do in the lab on a day-to-day basis, which is the genetics of ALS. Next slide. So this is a timeline of what we know currently about the genetics of ALS. It starts way back in 1993 with the discovery of the first gene for ALS, which was SOD1 by Bob Brown and Tipu Sadiq. And you'll see that there was kind of a long hiatus until sort of more about the 2000s. There was sort of a sort of influx of genes. And some of that is due to the discovery of C9orf72, which turns out to be a really sort of big player and big gene in both the ALS world and the FTD world. But also there's all those other little genes there that account for smaller and smaller percentages. And I think that reflects really the sort of growth in the technology and our ability to actually identify these genes as we go along. So there's a lot of groundswell of work that's been done on the genetics of ALS and a greater understanding. Next slide, Adam. And actually, Alan Renton, who was actually the first author on the C9orf72 discovery paper, he actually worked it out. He kind of put those figures together. And what he figured out was that about 2/3 of familial cases, we actually know now today what the genes are. That's great. Doing very well there. We're not so good on the sporadic side, where really only about 11-10% of the cases we actually know the underlying gene. So we've got some work to do there, and I think in order to make the gene therapy applicable to all of those sporadic cases, we do have additional work that we need to do in that arena. And I know that the ALS Association has been really generous and very helpful in supporting some of those gene finding efforts on an ongoing basis, both here and in Europe. Okay, next slide. Just to give you an example of some of the recent findings, this is one that we just recently published, where we found that actually expansions in the gene that causes Huntington's disease are a very, very rare cause of ALS. This is an area that had been open to debate for the last number of decades, but now we come out with some real sort of concrete data that we can hang our hat on, showing that actually that is a gene that does seem to cause both ALS and FTD without the chorea and without the actual diagnosis of Huntington's. Next slide. One thing that I particularly like talking about, because I started off as an epidemiologist, is using genetics to actually understand and identify lifestyle and environmental risk factors. And you might kind of go, well, wait a minute, genetics is genetics. How can you use it to actually find lifestyle factors? Well, it turns out that it's actually a very powerful method called Mendelian randomization, which is actually even more powerful than the traditional epidemiological study that is that are sometimes done to identify risk factors. And it's really kind of interesting, because what's emerging from that in ALS and actually in other neurological diseases is that cholesterol is a real important player in this. And maybe we might be able to change some of the behaviors with statin drugs to try and decrease cholesterol and thereby decrease people's risk of developing ALS. The same actually goes for exercise and smoking. You shouldn't be smoking anyway. Okay, nobody should be smoking anyway, but if you have ALS in your family, you really shouldn't be smoking, because it's an additional risk factor there. Next slide, Adam. And so we move on to really this kind of, what I've been talking about before really sets the stage for what's coming. And what's coming is this gene therapy. One could argue it's already here, but actually I think that we actually need to broaden it out a little bit and democratize it. So next slide. So I think that they're already emerging. You've got SOD1 antisense oligos, you've got C9orf72 antisense oligos from Biogen, and indeed also from University of Massachusetts. I put up this interesting drug from Elector, where they're actually targeting progranulin. The reason why I put it up, it's not really a gene therapy per se, but it is very personalized medicine and very specific to patients carrying progranulin mutations. And then, of course, we've also got the antisense oligos targeting the Huntington's from Wave Genomics. Next slide. But it's not going to be clear sailing. It's not all going to be easy. And I'll give you an example of that. I talked about Huntington's both as a cause of ALS and frontotemporal dementia, and also as the emerging antisense oligos. It turns out that Roche recently, and in fact Wave, had two HT drugs, ASO therapies designed against the Huntington's gene, and they both got shut down. So now out of the three, in 1 month it went down to one. And that was because really they found that even though the drugs seemed to be relatively relatively safe in the patients. The problem was it wasn't having much of an effect. And if you think about it, to a neurologist, this is actually might be fairly obvious for the reason why. And that is, by the time the patient comes to you, they've already lost so many neurons. In the case of Huntington's, it will be their basal ganglia. In the case of ALS, it will be their motion neurons, that really you can't get them back. And I sometimes say there's no drug out there that's going to rescue a dead neuron. You really have to get to the neurons before they're actually dead. So what it tells us, this is an important point, I think, and probably the most important point of my talk, is that you really have to treat these diseases early, and maybe even treat them before they even arise in the first place. So how do we get that? That's kind of, well, how are you going to do that? You're waiting on the patients to come in, and what are you going to do? Well, I think that again, genomics offers us an opportunity to do that. And one proposal that's been out there for many years, and I actually think it's coming to fruition, is doing whole genome sequencing at birth. So next slide, Adam. Now, it may sound fanciful, but actually, they're doing it in England. Every new birth in the UK is from a certain date in I think next year, is going to undergo whole genome sequencing as part of their national health screening. Of course, in America, the problem here is going to be who pays for it, who owns the data as a consequence, various problems like data storage and reanalysis over time. You have to know the genetic causes, though I would argue that if you're actually genome sequencing 4 million babies per year, you're actually going to catch on to the genetic causes pretty quickly over the course of a decade. And of course, the ability to intervene is going to be crucial to this. So again, we're talking about gene therapy. So in terms of at the NIH, next slide, Adam, what we're thinking about is what we're doing is we've set up a gene therapy program at NCATS. So NCATS is another institute at the NIH, similar to the way I'm at the National Institute on Aging. This is the National Center for Advancing Translational Science. And it's basically a mini pharmaceutical firm, biotech, inside of the NIH. And together with Don Lowe, who's this marvelous, marvelous pharmaceutical guy who's been around and who managed to come and work at NCATS, we're putting together this idea of how to actually get gene therapy available for all rare diseases. And of course, ALS will come under that umbrella, but we're talking about everything, not just neurological diseases, but metabolic diseases and everything. And of course, this is a real difference in our mindset because we're not talking about common diseases, we're talking about really rare diseases, N=1 clinical trials. But over time, as it develops and we get a groundswell of this, the idea is to decrease the cost and the development time so that the patient walks in, gets diagnosed as quickly as possible, and then the clock starts running and we try and develop that gene therapy as quickly as we possibly can. And one of the advantages that we have over other institutions and over other sort of companies is that we, as part of the government, we're actually allowed to liaise directly with the FDA and talk to them about this. So we actually have that ability to actually talk back and forth as to what is required in order to do this and make this a reality. So next slide, please. So I think that really this idea of precision medicine, it's coming to the fore. There's many aspects to it that I didn't cover today. Really sort of exciting time to be a neurologist because I think we're going to be really able to make a difference in the lives of our patients. Next slide, Adam. And just to summarize that basically number of cases of ALS is increasing. We know the genes for about 2/3 of familial cases and 1/10 of sporadic cases. The genetics can tell us about lifestyle factors, which is kind of surprising. Gene therapies are emerging, and really the key to this is going to be early diagnosis and sequencing at birth. Next slide, please, Adam. And I'll end with this slide. I started with Banting and Best. This is a quote that is very famous from Banting, and he actually sold the rights and the patent to the University of Toronto for $1 when he actually invented, right? Just for $1, on the grounds that the University of Toronto would make it broadly available to everybody. And as he said at the time, and I think that this is very important for anybody working in the government and anyone anywhere really, because remember, federal tax dollars underfund an awful lot of this research. that insulin does not belong to me, it belongs to the world. And I think that that's something that is important to remember as we move forward, that, if we're to apply this, what I don't want, and I don't think any of us want, is that these therapies are going to cost $1 million a year for each patient. That's just not feasible. We have to make it so that they're cost effective for everybody and accessible for everybody. All right, I will stop there. I'm sure I've gone over time, but I'm Irish. I'll keep babbling away until somebody tells me to stop.
Well, thank you, Dr. Traynor. That was a really fascinating look into the genetics and history of genetics for ALS. Next, let me introduce to you John Robinson. I've known John in the last sort of year or so, I would say, and he's a member of the ALS Association's Board of Trustees. Last year, he retired from the United States Army after nearly 32 years of service as a combat arms officer, strategist, and an educator. John is a person living with ALS and was diagnosed in 2019 while still on active duty. I'm so honored that John, when I invited him to speak, said yes. And he's here today to speak about prevention research from his very unique perspective. John, take it from here.
Thanks, Dr. Dave. Good afternoon, everyone. I appreciate that kind introduction, Dr. Dave. I often think of CALDIPS operation as the tip of the spear for our association's mission, translating hard-earned and generous donations into the tens of millions that we've already invested in promising research and therapies worldwide. Hi, I'm John Robinson. As Dr. Dave said, I was diagnosed with ALS in the spring of 2019 after having already lived with the disease over a year. And as you heard CALDIP introduce me there, if you're doing back of the envelope math, my final 2 years of active duty were with ALS, but I don't regret a thing. And that's why the association's research efforts are so important to me, because like every other ALS patient, I'm hoping for a breakthrough, but I'm also appreciative for interim therapies that might help to extend my life and along the way. And this is where I know we can leverage the untapped potential of the Department of Defense medical research efforts to maximize our opportunities to identify early red flags along the journey to ALS and possibly prevent the most egregious threats from taking hold. But for the military, this isn't merely conceptual. We already know the most common threats are toxicity and injury. And we know that toxic threats may include overexposure to petroleums, lubricants, lead-based ordnance, and foreign environments. And we know that injurious threats may include traumatic brain injury, aircrew exposures, including violent vibrations and gravitational forces. And reduction or prevention of these threats is happening now and ongoing. Better and more enforced use of personal protective equipment can help us reduce the threats of toxic exposure. And we've already reduced the lead content in some of our ordnance, and we've identified additional preventive measures for open firing ranges. But it's the field of traumatic brain injury, what we call TBI, that has shown particular promise. This year, just over a month ago, in fact, the U.S. Army Medical Material Development Agency, in partnership with a private pharmaceutical company, announced that the Food and Drug Administration had approved a traumatic brain injury plasma assay, a rapid blood test designed to detect TBI. Developments like these can help TBI diagnosis in a wide range of impact activities beyond the military, including sports and law enforcement, which can prevent lasting damage. For several years, some military trainees have been screened for the sickle cell disease. We can expand this practice of identifying biomarkers in new recruits, potentially even including genome testing for ALS. In this regard, it would be beneficial to establish a complementary partnership between the Centers for Disease Control Registry and Biorepository and the DoD ALS Research Program. For example, CDC could fund identification of new risk factors, and the DoD ALSRP could then fund follow-on therapeutic studies against that particular risk factor. This is why the association strongly supports continued funding of $10 million for the CDC, and we're requesting a funding increase in DoD ALSRP from $40 million to $60 million. 4 years ago, I managed the studies and research portfolio for the Army's largest four-star command. And the Army, like its sister services, Air Force, Navy, Marine Corps, has several studies programs scattered among their colleges and higher level commands. And these are fully funded programs. And they solicit research concepts from subordinate commands. But the potential to leverage those programs in service to further our understanding of ALS, both inside and outside the military, is still largely untapped. Let's get it. These service programs are exclusive of the DoD ALS research program, above and beyond. But just as important, we must identify opportunities where the interests of the service research programs intersect with the ALSRP, and it's imperative that not only do we enlist these programs in support of our prevention and therapy goals, but that we help ensure all of these research efforts, service and DoD ALSRP, are all rowing in the same direction. Look, we know that 1 in 6 ALS patients is a veteran. Sometimes being struck while still serving, like me. And we know that veterans are twice as likely to be diagnosed with ALS as those who haven't served. As I shared with my remarks to the FDA last month actually, this represents a national security challenge to our country. But I'm confident the Department of Defense recognizes the challenge. Gaining increased funding for the National Institutes of Health, the Centers for Disease Control, the Department of Defense ALS research program, leveraging the military services fully funded research programs, and getting everyone to row together as a team. This is the tripartite approach to enlist the military as a fully committed partner in our mission to make ALS a livable disease in my lifetime. I appreciate everyone's interest in better understanding this art of the possible in prevention. Together with our military and government teammates, we can make prevention and therapies real, and I thank you. Good afternoon.
Thank you, John. Just amazing. I could listen to you all afternoon. Thank you for sharing your insights and just a unique perspective that you bring to us and to this community. Next, I would like to introduce Dr. Jill Yursak. She's Vice President of Mission Strategy at the Association, and I'm so excited for her to present today on how do we start delaying harms and complications of ALS. Jill?
Hi, everyone. Thank you, Kolda. Thank you for having me and for the kind introduction. Advocacy Day is my favorite day of the year, and I'm hoping we can all be back in person next year. So the work the association is pursuing to help reduce ALS complications that I'm speaking to today was really born out of the ALS Roundtable program. And the goal of the ALS Roundtable is to bring together our diverse stakeholder community in a now virtual place to identify challenges and collectively brainstorm potential solutions to large issues that our community faces. So for example, we've covered areas like accessing new therapy, support services, and care, and also things like reducing time to diagnosis. And these are really big problems that the association ourselves cannot solve on our own. But today I'll be focusing on our work that came out of the Roundtable program for reducing ALS complications. So last November, we met over 2 consecutive days virtually with more than 75 participants. And this included our corporate sponsors, which are now 12 and counting, subject matter experts like clinicians and researchers, some of our government partners like the FDA, members of the International Alliance for ALS-MND, and most importantly, people with ALS and their caregivers, to hear their perspectives and experiences around how ALS impacts their lives. And it's really an excellent opportunity to collaborate and share ideas. Next slide, please. So people with ALS face a multitude of physical, psychological, emotional, and financial challenges as they navigate their disease. This disease journey is often complicated by other conditions associated with ALS. And such complications, and I'm going to refer to them really as symptoms that result from disease progression, but often lead to emergency department visits, inpatient hospitalizations, and even death. And they cause pain, distress, discomfort, fatigue, reduction of quality of life, and a negative financial impact for people with ALS and their families. And many of these complications in our minds can be prevented. And our conversations were among the first to focus on these issues in a multi-stakeholder format last November. And the association has identified reducing and preventing complications from ALS, and thereby providing the lives of people with ALS and their caregivers in the association as a near top-term priority. Based on these conversations, we believe it's possible to reduce the frequencies of these complications and improve the experience of people with ALS and their families. So at the Roundtable, several leading clinicians in ALS helped me present the perspectives on top complications of ALS, which they categorized here on the slide, which are infections, respiratory muscle movement, pulmonary embolisms, GI issues, difficulty swallowing, which is dysphagia, weakness, immobility, spasticity, and cognitive issues that are shown here on the slide. And within these categories, there's often a cascading effect without proactive intervention, where one problem can lead to multiple compounded problems with increasing severity and intensity. But we believe with the right intervention, it is really possible to reduce the frequencies of these complications. Next slide. So what I want to share today was in preparation for our roundtable, and that we commissioned a review of Medicare claims data by an actuarial research corporation to determine what types of complications people with ALS in the Medicare population were seeking medical care for. And so we conducted a review of a nationally representative sample from Medicare fee-for-service claims data from 2016 to 2019. So that's over a 4-year period. And it indicated that most people with ALS in the U.S. are covered by Medicare, either as their primary coverage in conjunction with Medicaid, which are people who are dually eligible, or as a secondary coverage to private insurance. And so people with ALS who are under 65 years of age can now qualify for Medicare through Social Security disability insurance without a 5-month waiting period. And this is a great accomplishment that our community has achieved in the recent year. And according to this analysis, there are approximately 16,000 people with ALS in Medicare fee-for-service each year. And we want to know the top reasons why people with ALS go to the hospital. The emergency department, of course, and then inpatient stays. And those inpatient stays result in multiple days in the hospital, unfortunately. And this information provides insight into the top serious complications experienced by people with ALS, prompting a trip to the hospital. And this analysis was conducted comparing people with ALS to other Medicare beneficiaries, so to see if the complications experienced by our population are similar to or more common than the general Medicare population. So due to the timing restraints today, I will just focus on emergency department and inpatient encounters. So I want to start with emergency department because it's likely the most common entry point for people when they seek out hospital-based care. So if you get hurt, you're going to go to the ER. And then they decide whether or not they're going to admit you for an inpatient stay, depending on what happens at the ER visit. So on average, we found ALS beneficiaries visit the emergency department twice as often per month as does the general Medicare population, and 3 times as often when the ED visits results in hospitalization. You can also see the number of total inpatient stays are increased in the ALS population almost 3 times as many, and the number of total inpatient days are increased in the ALS population almost 4 times as many. And importantly, this slide shows the top 6 reasons people with ALS visit the emergency department and are admitted for inpatient stays. And you can see from the main reasons are infection and respiratory issues. And which was interesting because that's what our clinicians had showed us are some of the top complications that they identified earlier in the day at our roundtable. And we're also curious about the role of falls in an emergency department visit. And the analysis found that falls were a factor in about 14% of ED visits compared to 11% in the general fee-for-service population. So while falls was a great factor in ED visits for people with ALS, they're not as big as a factor as we originally thought. So, as laid out in our strategic plan to make ALS livable by 2030, one important part of this is to reduce harms for all people with ALS and their caregivers. We're already doing this now. Programs to reduce ALS complications are underway all across the country, and our chapter network are making huge impact on our community. So for examples, our chapters are implementing family caregiver boot camps, which are designed to inform about the role of the caregiver, how to use common pieces of medical equipment, and how to recognize and deal with complications of the disease. We also have a Y Care program, which is a lot like the caregiver boot camps, but it's really designed for children 18 and under. Because as we found, many children under 18 find themselves in the position of not maybe being the primary caregiver, but a huge part of their care team in the home. And we want to empower children across the United States to be comfortable about and really empower them to help their family navigate their disease. We also have equipment loan programs across the country where people can loan things like mobility devices and even communications devices. And those are things we've been working on for years. And we've been helping to prevent infections by teaching appropriate care of things like feeding tubes, urinary catheters, and trachs. And those are really big reasons why people have to go to the ER for those types of infections. And there's programs out there that we can continue to build upon to help really prevent having to go to the ER or inpatient stays. Next slide, please. So, to pull all this together, chapters play a huge role in research across the country, and our strategic pivot really to reduce harms in people with ALS will help integrate research and in the chapters in a way like we've never done before. And my example of how we can reduce complications through thoughtful programming is just one way the association is helping mitigate ALS complications. There's so many existing programs that I would love to talk to today that are underway, but I just don't have time. But importantly, we're really sharing lessons learned and best practices. We're learning from each other. And this will elevate us to another level for inspiring high quality care to reduce harms for people with ALS. So overall, our systematic approach will lead to optimization of care. It will ensure that we reduce harms for all people with ALS and their families. And together, we will reduce patient and caregiver burden to increase quality of life. And this all directly contributes to making ALS livable by 2030. So thank you for having me again. I'm going to stop here. And now I'm going to kick it back over to Nicole to start our Q&A session. Thank you.
Thanks, Jill. And for those of you that were not with us yesterday, I am Nicole Eck, and I'm the Vice President of Operations for the ALS Association. And I'm going to be managing our Q&A today, where we're going to welcome back several of our speakers. But first, I want to let you know two things as far as housekeeping goes. We're running a little bit over time, but we want to keep this Q&A session going a little bit further out from our end time, because I have some really, really good questions coming through, and I want to be sure we have an opportunity to hear some answers to those questions from our great speakers. But the second thing I want to do really quickly is share some really exciting news with all of you that's really kind of been happening over the course of the last 2 days. So I have a few updates for you on some legislation that I will actually refer to my paper here in front of me, so I make sure that I give you all of the information properly. So first, I want to share that you just heard from Representative Diane DeGette from Colorado about the new Cures 2.0 bill. I do want you all to know that the ALS Association has submitted 2 sets of very specific recommendations on ALS issues to Representative DeGette and other congressional leaders specifically for this bill. We will let you know as soon as that bill is introduced, and certainly there will be a call to action around that bill. Secondly, yesterday, the Promising Pathway Act was introduced in the House by a bipartisan group of representatives. As you know, Senator Braun has already introduced the Senate version of this bill, and I hope you will join us tomorrow when you will hear remarks actually from Senator Braun about the bill itself that creates a new provisional approval pathway at FDA for serious diseases like ALS. Third, early next week, we have teams of people living with ALS and their families meeting with a targeted list of senators and representatives on appropriations on Act for ALS and the Promising Pathways Act. My fourth message for you all is that later next week, we will kick off a very intensive phone campaign to reach every member of Congress. That is our goal. On June 17th, we will invite more than 40,000 advocates, including everyone in this conference today, to call or email their members of Congress to ask them to support and pass the Act for ALS and the Promising Pathways Act. So please be ready to join us in this effort. And without further ado, I am going to kick off our Q&A session. So I will welcome back all of our fine speakers today. Dr. Brian Traynor, we have John Robinson joining us again. We have Dr. Jill Yursak joining us again, as well as Dr. Kuldip Dave. So thanks all for coming back to join me for some questions. So it's been kind of a furious flow of questions actually since the very beginning of the second session here. So I'm gonna start really with Dr. Traynor. I have a lot of questions around genetics specifically for you. And so you were talking a lot today about gene therapies for the most common genes like SOD1 and C9orf72, and also for more rare genes. And so I have several questions about that specifically. Are you calling for genetic screening for testing at risk family members or for ALS patients in general?
Well, okay, so I think that most ALS patients, when they attend clinics, certainly in major medical centers, they undergo genetic testing. Nearly all at this stage, certainly of the more common genes. So I really wasn't talking about that. I was, my remit was to think of this utopia 10, 20 years in the future as whereby we can actually prevent ALS from ever occurring in the first place. And the point I was trying to make is that in order to actually prevent ALS, we're going to have to identify the people at risk early on. So one mechanism, and it's already being put in place in the United Kingdom across the pond, is to actually genome sequence everybody at birth. And you can imagine that over a period of decades, you'd actually end up with everybody, you would have everybody's genome, and we would be able to work out what all of the genes were that caused this disease, this horrible disease, and then act on it as the gene therapies became available. So I apologize if I misled anybody. I was kind of trying to give a utopian vision of where we want to be and how do we get there, rather than sort of advocate, well, everybody should be running to their doctor and getting tested for X, Y, and Z genes.
Thank you, Dr. Trainer. I appreciate that. I think I have a follow-up question for that. And specifically, if people are interested in getting any kind of at-risk testing, especially for family members, when would you recommend that they do that? Or I guess the question is specifically more about when is it recommended for family members to get tested?
Yeah, no, that's a question I get asked a lot by my patients, and I think it's a reasonable question. The answer may surprise you a little bit, and that is, I don't get to answer that question. The family member, the unaffected family member, is the one who gets to answer that question and make that decision. But they don't make that decision on their own. They go to their primary care physician and they discuss it with them. And if they want to even get more information, they ask for a referral to what's known as a genetic counselor. The genetic counselor, this is sort of a whole area of medicine that's grown up around the idea of genetic testing. And they fulfill certain really important functions. So first and foremost, they tell you the information behind it so that it allows you to make the decision in an informed manner. Not only do they tell you the consequences of having a positive result, they also tell you the consequences of having a negative result, which can actually be, some people can get quite upset about that. And they can tell you the consequences of deferring it to a later date, the testing to a later date, or never having it at all. So really, there's a whole mechanism there to enable unaffected family members who are interested in genetic testing to pursue it. It doesn't go through me, it doesn't go through my clinic, it goes through the genetic counselor. And I think that most neurologists, when they're faced with that question, they will have a similar answer. They will refer on to a genetic counselor.
Nicole, can I follow up on this? It's also important to note that just because you have the gene doesn't mean you'll get the disease. Just because you have a particular mutation. And so, you know, and the other way around, just because you don't have a gene doesn't mean you won't get ALS. We know that, you know, sporadic disease and things like that. And so, this is a point that I was trying to make early on. Just because you live near a freshwater lake doesn't mean you're always going to get ALS. Just because you have a particular gene mutation doesn't mean you're going to get ALS. And some people go on to get the disease and some people don't. And so it's important to also think about in research what protective factors are. You know, what is protecting you from that mutation that you're not going on and getting the disease? Or what is protecting you when you live next to a lake that somebody else didn't? And so I think this is an important conversation. This is why I think what Dr. Trainer is recommending is it's not just about genetic screening, but it's also getting counseling. It's very important because it's a complex disease and it's a complex answer, and it's something that you need help with. A counselor can help you understand those results.
Thanks, Kuldip. And you actually answered, I think, a couple other questions that I was receiving specifically about if all ALS is genetically linked. And I think you helped to point out the difference to some of our newer attendees to the advocacy conference and to this conversation, that not all ALS is attributable to a gene at this point. So I'm going to move on actually to you, Kuldip, for a moment, because you actually were just talking about some other types of risk factors. to be considered. And I have a question specifically about exposure. So are there studies for people called it who have ALS who were exposed to lake water that has had blue-green algae blooms?
Yes, there are a couple of studies, in fact, that are going on. The first one is at the CDC, the National ALS Registry. As you know, it's not just counting the number of people with ALS. It's not, but it also collects specimens, and it also collects what we call exposome data. Exposome data is what have you been exposed to? Where did you live? Where did you work? And I know that Dr. Trainer actually has one of the projects from CDC looking at gene sequencing, but the CDC is funding a couple of studies currently where they are looking at this exposome data, people who live near lakes, freshwater lakes, in particular areas, whether it be Florida or up in the Northeast or Michigan, and what that means to risk of ALS. By the way, these studies are not easy. I think Brian talked about epidemiological studies. It's a rare disease to begin with, and now you're talking about people living in a particular area, and we know how few of those people get ALS. And so, a lot of these studies, Nicole, need a lot of validation. We at the ALS Association are also funding actually two different studies. One is with Dr. Elijah Stummel, who is following up on the CDC funded study where he's looking at nasal swabs and lung biopsies and looking at exposure data to cyanobacteria and blue-green algae and trying to correlate that with risk of disease. So this is a really, pun intended, green area. This is, it's where I think we're going to find those risk factors of tomorrow.
Dr. Trainer?
Yeah, I just want to add, I started off as an epidemiologist. My first doctorate was in epidemiology, and it's so hard and nuanced and complicated, as Kuldeep said. I left it and I went into genetics instead. So it gives you a sense of how complicated those things are. But I will say that over the last 20 years, the tools to dissect out the exposome have developed more than they were. And now we're really at the point where actually with funding from the ALS Association and other organizations, it's becoming possible to get a definitive answer on these environmental toxins and to determine whether they really do cause disease, in what subpopulation do they cause disease, is there anything specific about that we could actually go after in terms of therapy, in terms of understanding why motor neurons die, that sort of thing.
Thank you both. So I have a couple of questions here specific to prevention. And so Kuldeep and Jill, I will allow either one of you to pick up this question, whoever you think is best suited. But when we're thinking about prevention, a lot of people describe, ALS as sort of being a spectrum of diseases, right? It starts differently in every person. It progresses differently for every person. So this particular individual said that they've heard many describe ALS symptoms developing immediately after surgery or an injury. We haven't heard this discussed as a potential trigger, but do you have any thoughts on, potential triggers of ALS, or is there any research being done in that area?
So I'll start, Kuldeep, if that's okay, and then you can follow. So yeah, I've heard anecdotally a lot from different people with ALS and their families that everyone has a story, right? Like something happens, they're like a car accident, or they got hit in the head with something, or they were a professional. I once worked with a professional hockey player, and he had lots of blows to the head that he felt that couldn't have helped his cause. And so, I think a lot of this work, like Dr. Dave and Dr. Trainer says, it's hard to validate. You need large populations of people to really understand if that is the real trigger and those types of environmental risk factors. So what I believe is that a lot of these things, especially things like a traumatic head injury over and over again, that we've seen like in football players, for example, or even soccer players, could be a trigger that plus if you have a genetic background that they didn't know about, together it could increase your risk, I think, for ALS. So there's a lot of work to be done, and I think it's fascinating, but this research is going to take some time to really pull apart what could be those environmental risk factors that really we should start to stay away from. So Cole, do you want to add?
Yeah, and Nicole, thank you, Jill. This gives me an opportunity to share with our community that the ALS Association brought together experts from all over the world last year, and we did a prevention workshop. So this is not, something that we just unveiled a strategy and research around it. We have been thinking about this for a good year now, and in fact, Brian Traynor was at that workshop. And we talked, Nicole, about these other types of risk factors. We discussed head injury. There's a story around soccer players in Europe. I don't know if that's what funded Dr. Traynor earlier, and that was the goal. We talked about viruses. Everybody's talking about coronavirus, and so these days, and we talked about, is viral exposure something that increases your risk of getting ALS. There could be, as Jill said, multitude of these risk factors. And how do they, in that workshop, what we discussed was, how do we start to parse this out? There's so much data, but there's so much one-off data. How do we gather more data around each of these risk factors so that we're more confident that this risk factor is indeed linked with ALS and it's not a random finding? And so Dr. Traynor and some others from that workshop are actually now helping the ALS Association think about a strategic roadmap on how we get to prevention and what's needed and what are the organizations that would need to, as John said, row in the same direction to get us there, to start to answer some of these questions.
Thank you both. And you actually are leading me right to a question for John. John, I have a couple of questions in here specific to the Department of Defense that I'd love to direct to you. So first of all, regarding some of these areas of study that we're hearing about today, is the DoD or the VA working in these areas of study around prevention?
So as a former safety officer, I can tell you that the services actually have prevention worked into virtually every mission that they accomplish. It's sort of underlying the wave tops. It's literally part of every order that you issue. With that said, one of the ways that we can row in the same direction, as Kuldip said, is that just 8 years ago, the Defense Health Agency was created as an overarching headquarters to synchronize the actions of the Army, Navy, and Air Force, Navy providing the healthcare for the Marine Corps as well. And when you have a single agency that can help the services row in a common direction, they can also spearhead some of these prevention efforts. So as an example, I saw a solicitation just this year from the Defense Health Agency and its Army component to solicit concepts in support of the DoD ALS research program. This is the way we get everyone to row in the same direction, with one headquarters that manages all the services, working together hand in hand with the DoD ALS RP.
Nicole, can I just add to this? First of all, I forgot to mention when I said Brian Trainer was at that workshop, you know who else was at that workshop? John Robinson was at that workshop. And he provided, and he was there with, I think, 3 or 4 other people living with ALS, John, if I remember correctly. And they provided perspective on how we think about this. You know, John mentioned these different agencies. They were also there at that workshop. We had representatives from Department of Defense, from NIH, from CDC, and from the VA, so that we can all think about, you know, this is a complex disease. Treatments are, you know, challenging to come by. Now we're thinking about prevention. And so it's not going to be, it's going to take a village, and it's going to take coordinated, collaborative efforts to go after this. And so thank you, John, for talking about how these different agencies can come together. Thanks, Nicole.
Yeah.
I appreciate it. I'm going to round us out with one more question, I think for you, Jill and Coldet. You know, as we're thinking about this new area of looking at prevention in the area of ALS, will the ALS Association or other groups create either a database or some kind of way of tracking to see if some of these preventative actions we're hoping to take, and as well as treatments that are currently available or might be available in the near future, will we tracking the reduction of symptoms as an example, and how can we measure success overall? Is there any thoughts on that right now?
Do you want to start, Coldet, this time?
Sure, I can start. So this is something, Nicole, we talked about quite a bit at the workshop, which is, you know, I talked about the CDC funding a couple of studies. I talked about us funding Dr. Stummel to look at environmental risk factors. And this type of research is going on across the world. So how do we start to put that type of data together so that we can maximize the numbers and we can be confident that this particular risk factor is linked with the disease? And we have experience in this. The ALS Association has made clinical trial data public. We have, I think Dr. Jinsey Andrews talked about this yesterday, the PROACT database. So this is where the clinical trial data is made public, anonymized, and all of that, but so that people can go analyze that data. We're doing that for genetics as well. In fact, I hate to keep coming back to Brian on this, but Dr. Trainer and Dr. Glass and Dr. Landers are leading an effort where they're bringing all of the genetics data together into one single database, which then can be made publicly available so that the rest of the world researchers can analyze that data. And that's, you know, we have experience doing that with both clinical data sets and genetic data sets. And what the goal would be to, you know, start to develop an idea and framework around what that prevention data looks like. And how do we put that together in one place so that that can also be available for researchers around the world to analyze.
Yeah, if I can, Nicole, this is an area that I touched on earlier where there is still so much potential for the Department of Defense to contribute to this data set in the ways that Dr. Trainer described earlier. We are doing some of these things in the department now with trainees, but there is more that could be done in terms of early testing to establish some of these baselines so that we can go back and look at them if there are diagnoses later in career.
And I just want to add, you know, we at the association are huge proponents of sharing data, especially across studies. We use things called the Global Unique Identifier, which can connect large studies like the ALS National Registry to clinical trial data, to some of these huge genome sequencing consortia that we're working with. So the goal is to harmonize data, to share data, and not reduplicate. We don't want to duplicate. That's everyone. It wastes everybody's time and everyone's money. So we are huge proponents of that, and we're putting things in place and constantly encouraging all of our grantees that they share and sometimes even require to share data through global unique identifiers and other ways. And the other thing is that at a local level, some of these things that we're working on for complications, for example, we're going to start collecting data to see and show that some of these great workshops and boot camps are making impacts. Like, are these caregiver boot camps are they preventing falls? Are they preventing infections? And so we're going to be doing a lot of more data collection on a national level to really show show the impact that the association has, because we have the impact, we know it's there, but we, as a scientist, and Dr. Trainer can, I'm sure, say, is like, we love data. We want to see that data and show that there's a really big impact there. So, and as we collect that data, we're going to be happy to share that throughout the next year or two. So something to look forward to, more data from us.
Well, thank you all. As yesterday was such a good discussion, this was equally as great. And I could just listen to you all talk about this all day. There's so much to learn and understand. So I really appreciate you all being with me today. And here at our conference, we really appreciate Dr. Trainer, John Robinson, Dr. Kuldip-Dave, and Dr. Yurcek. Thank you so much. And it's time to wrap our day 2 of the 2021 National ALS Association Advocacy Conference. So thank you to each of our speakers once again, and to you all for joining us. I know that there are hundreds of you watching us right now. So we look forward to you joining us again tomorrow. Our program again will kick off at 3 o'clock Eastern. So we look forward to seeing you again, and we'll do more of this Q&A in our 3rd session tomorrow. Have a great night, everybody.